So this is how I want the students to approach hand infections. This gentleman had a small penetrating injury, which has now become increasingly painful and swollen. So that's the history. You need to know about the patient as well. Does he have any comorbidities? How long has it been going, etc. But I just want to focus on the examination of this patient. The first thing you want to do is look, and when you look, you can see an obvious swelling, yellow discoloration over the mid aspect of the palm. If you turn him over, turn over, sir, turn your hand over. You see there's not much in the way of swelling. It's a little bit more swollen than the other side, but not a whole lot. It's definitely swollen, but this swelling is non-tender. So it's really the discoloration. You can also notice the previous scar over there. This is an interesting case because it's slightly atypical, but I'll get onto that in a second. Then when you want to feel, so it's look, feel, move. When you want to feel, you want to feel for local tenderness to identify where it's tender. Now, obviously here, this is a very important sign. I don't know if you can see it on the video, but this is what we call fluctuance. So you can see if I push there, it bulges there, and if I push there, it bulges there. So this is fluctuance, and it goes in both planes. So it's bidirectional fluctuance, cross fluctuance it's called. So it's obviously tender and swollen there, but there's also some tenderness over here. When you open and close his fingers actively and passively, that's the next thing you want to do is movement. So it's active movement, make a fist, open up, and then you want to do passive movement as well. Okay, and you want to ask him to move his thumb across the little finger. Can you bring your thumb across? He doesn't really like to move his thumb very much. So this could be a typical infection or an atypical infection. The learning point today is that there are 5 recognized hand infections. Number 1, infection around the nail called a paronychia. Number 2, infection of the pulp. It's mostly the terminal pulp, it can be the middle or the proximal pulp. That's called a phelon or phelon. Infection number 3 is a Webspace abscess. That's in there. And this guy's slightly tender, and there's slight pushing apart of these fingers, which is the cardinal sign of a Webspace abscess, pushing apart of the fingers, splaying of the fingers. So this could be going towards a Webspace abscess that's presenting superficially more proximally. The 4th infection is a Flexor sheath infection along the whole Flexor sheath. That's usually a very easier to identify infection because it's the whole finger swollen and tender. The patient doesn't want to move at all, and if you passively extend the finger, it's exquisitely painful. That's the 4th infection, Flexor sheath infection. And then the 5th infection, which this might be as well, is the deep palm infection. So there's an infection underneath, deep to the flexor tendons, between the layer of the flexor tendons and the lumbricals, and then the interossei deeper down. And then that gets divided by a band in the mid aspect of the hand. It's a fibrous band, scepter that goes down to the middle metacarpal, and you get a thinner-sided and an ulnar-sided deep mid-palm infection. Now this guy's slightly tender here, so this could be that case. So it's either an atypical subcutaneous infection from a laceration, or it's a deep mid-palm infection, or it is a web-based infection. So the management of this patient will be, number 1, adequate anesthesia, not analgesia, anesthesia. You can't be just lancing this thing and draining it. So you need a proper anesthetic, whether it's regional, general, or you can't really do local, but you might be able to get by with a wrist block here because it's out of the zone of infection. Number 1. Number 2 is you need a bloodless field. So you'll need an above elbow tourniquet. Elevate for 2 minutes to drain all the blood. Do not use a constricting Eschmark type bandage. Just elevate for 2 minutes and then make it a bloodless field. And then once you've got adequate anesthesia and a bloodless field, you will make a longitudinal incision and drain the pus, take a pus swab always, and then see where the infection is coming from. If it's coming from the web space, I would extend the incision towards the web space. If it's coming from the deep mid-palm area, I would extend more proximally, watching out for the very critical nerves, vessels, and tendons, and then go down deep to the tendons to drain the mid-carpal space. And then this patient will need appropriate antibiotics, initially empiric, and then once the pus swab result comes back, the definitive antibiotics.